Here I would like to present insights derived from both my clinical practice and personal experience regarding COVID-19 management, focusing on the therapeutic use of low molecular weight heparin, particularly enoxaparin, behind its anticoagulant activity as a potential heparan sulfate regulator. This discussion is rooted also as someone who has personally encountered the challenges of this unprecedented global crisis, the COVID-19 pandemic caused by SARS-CoV-2 virus and rapidly escalated into a global health emergency. As of now, the World Health Organization reports over 770 million confirmed cases worldwide. The rapid spread and devastating human toll highlight the virus's virulence and transmissibility. Despite extensive research and remarkable efforts to develop therapeutics, the quest for optimal treatments remains an urgent priority, particularly as the pandemic transitions into a prolonged post-COVID era. It doesn't relinquish our lives in 2025, as reported by WHO also. Among the many impacts of COVID-19, the significant rise in neuropsychological issues among patients had underscored the necessity of exploring underlying mechanisms. My professional journey during this crisis led me to investigate the potential of low molecular weight heparin, particularly enoxaparin, in the therapeutic landscape of COVID-19. This interest was sparked not only by my clinical observations but also by a personal experience in the spring of 2020 when I sustained a severe ankle fracture while preventing an accident involving my husband. This injury required self-administering enoxaparin, providing me first-hand insights into its efficacy and convenience as an anticoagulant for the first time. Meanwhile, in my clinical practice, I consulted a diverse cohort of COVID-19 patients ranging from mild cases to those with severe complications. Many consultations occurred online due to the pandemic constraints. A detailed summary of 8 selected cases using low molecular weight heparin demonstrated significant improvements behind its anticoagulant properties. For instance, one patient with positive PCR, elevated D-dimer levels, and side effects from hydroxychloroquine, suffered also from edema and anxiety, experienced marked recovery following enoxaparin-based personalized therapy. While WHO guidelines in 2020 recommended thromboprophylaxis with unfractionated or low molecular weight heparin primarily for patients with severe acute respiratory distress syndrome, emerging evidence and clinical observations suggest that low molecular weight heparin may offer additional therapeutic benefits. Beyond its anticoagulant effects, low molecular weight heparin exhibits anti-inflammatory and antiviral properties which could contribute to improved outcomes in COVID-19 patients. At that time, to disseminate these findings and insights, I have shared my research and experiences at various platforms including WHO, FDA, ResearchGate, and notable conferences such as the 2021 Congress of Alzheimer's Disease in Thessaloniki, and also in 2023, and Congress of Orphan Drugs and Personalized Medicine. My hope is that these contributions will aid in advancing our understanding of COVID-19 therapeutics and provide valuable guidance for future interventions in managing both acute and long-term consequences of the pandemic. Building upon my first observations of remarkable improvement in COVID-19 patients treated with low molecular weight heparin, I hypothesized that this regulation of heparan sulfate may play a crucial role in the early pathogenesis of COVID-19. This hypothesis drove me to explore the potential therapeutic and preventive applications of enoxaparin in a structured manner across 3 distinct groups. In active COVID-19 patients consisted of 51 patients. In normal individuals, as a preventive measure, including myself, family, and friends, consisted of 10 persons. And post-COVID-19 patients experiences lingering side effects consisted of 53 patients. All participants provided informed consent, either orally or in writing, before inclusion in the study. Baseline D-dimer levels were measured to guide therapy, but did not limit enoxaparin administration, as it was prescribed based on clinical symptoms rather than laboratory thresholds. Each participant received at least 6 injections of enoxaparin at a dose of 4,000 units, adjusted for their specific symptoms and clinical condition. The preventive group individual received 1 enoxaparin injection every 2 weeks, aligned with the incubation period of SARS-CoV-2, with additional doses as needed. In the post-COVID group, patients received a minimum of 4 injections, spaced 1 every 2 days, with the dosage adjusted to symptom severity. Most participants were monitored remotely, primarily through WhatsApp consultation, to ensure safety and adherence while maintaining patient access during pandemic restrictions. Patients presented with a range of symptoms from mild to severe, and enoxaparin demonstrated a striking ability to alleviate these symptoms, even in severe cases. In the preventive group, no disease occurred, and all participants remained disease-free for at least 6 months, with only 1 very mild COVID-19 case reported compared to household controls. In active COVID-19 group, patients receiving enoxaparin in conjunction with supportive care showed rapid symptom improvement. In contrast, controls relying on supportive care alone or remdesivir experienced more severe disease, including the 1 fatality. In post-COVID group, those treated with enoxaparin recovered significantly faster from severe neurological and skeletal symptoms compared to controls, who exhibited a prolonged recovery time. Enoxaparin's broader therapeutic benefits likely stem from its ability to modulate inflammation and possibly disrupt viral pathogenesis linked to heparan sulfate dysregulation. These findings not only underscores the necessity of individualized, mechanism-driven approaches, but also opens new avenues for therapeutic interventions that extend beyond the confines of traditional guidelines. Now, a little bit about heparin. Heparin is a naturally occurring polysaccharide in the body, while low molecular weight heparins are derived from unfractionated heparin via enzymatic or chemical depolymerization. Both exert anticoagulant effects by activating antithrombin. Low molecular weight heparins have largely replaced unfractionated heparin due to their superior safety profile, including a lower risk of thrombocytopenia. They also allow for outpatient treatment of venous thrombosis, reducing the need for hospitalization. Heparan sulfate proteoglycans found in the extracellular matrix and on the cell surfaces are essential regulators of physiological and pathological processes, mediate critical functions including cell signaling, immune defense, and interactions with pathogens. Most laboratory and simulation experiments studies have shown benefits of using heparin in COVID-19, but clinical studies have shown inconsistency that may be rooted in heterogeneous methodologies and patient population and conflict of interest that is mentioned by the authors. In conclusion, although I am neither a virologist nor a pharmacologist, I firmly believe that the future lies in the development of innovative low molecular weight heparin derivatives tailored to balance antiviral, anti-inflammatory, and anticoagulant properties.
Thank you very much for your attention.
And so many thanks to Professor Cholaki that has brought us all together again.